session will be distance learning platforms. I'd like to introduce my panelists. Mark Mitchell, President and founder of D-Tree International. Sabina Beatrice, with Project Manager with Novartis Foundation. Miriam Yanakis, Nutrition Policy and Advisor for World Vision. And Nathan Pankowski, founder of Bull City Learning Systems. I'll leave it to them to expand on their introduction when they make their opening comments. So I am the moderator. My name is Jane Mackenzie White. I'm with the Johns Hopkins Center for Clinical Global Health Education. Our center is focused on supporting researchers and providers through education and training. We've been successful over the last 9 years developing programs in over 20 countries. As co-organizers of this summit, I'd also like to welcome you again and thank you for participating. And as a reminder about the format for this summit, as you'll see in all conferences and as you saw earlier, audience participation is encouraged, in fact, expected. And I will turn to the audience after initial questions for the panelists. So be prepared. So I think we could all probably agree that distance learning expands access of education and training. And as the minister pointed out earlier, there is a shortage of healthcare workers globally to the tune of 4 million. And as Dennis O'Brien also pointed out earlier, there is no lack of innovation, even in areas that lack resources. So I'd like to ask the panelists to respond. Why then has distance education strategies not been widely adopted in the healthcare sector in terms of training? And what can be done to optimize the uptake of these strategies for training of healthcare workers? And why don't we just go down? I'll start with Nathan to my right.
Okay, thank you. Just before I answer the question, I'll just say a little bit about myself. When I first sat down here at the conference, somebody asked me if I was a techie or if I was a medical person, and in fact, I'm neither of those. So I'm not sure if I'm one of the few or one of the many, but I'm neither of those. I'm actually an educational psychologist and an instructional designer. So in some ways, I sort of, at least in my role here in global health, I kind of straddle the line between those a little bit. And what I've done for the last 20 years is helped organizations of all sorts engineer meaningful and effective learning experiences that can be delivered at a distance using technology and various other forms. So that's really my background, and I've actually been in global health for about 18 months working on a number of different sorts of projects, largely in the area of immunization. And I think just so that you know kind of a point of reference here, one of the things that I worked on last year was something that we were calling a global health distance learning landscape. And what we did in that report was we profiled about 35 or 36 different distance learning initiatives that were occurring in global health and in other sectors as well, in ag and even in the private sector and in K through 12 and things like that. So I'm just mentioning that because my point of reference on a lot of these things will stem from or kind of flow out of that work we did on this on the landscaping report. So the question about why has there not been uptake, better uptake of distance learning into global health? And I would argue, having had exposure to a lot of other industries and even in the developed worlds like in the United States and Europe, that they struggle with uptake of distance learning as well. In fact, attrition rates in distance learning programs are extremely well known. And we hear a lot of talk these days about things like MOOCs and Coursera and Udacity and how they're going to radically change university education and things like that. But in fact, I think it's Udacity silently sort of pivoted its strategy and has changed direction and is really trying to focus more on the corporate market. And its justification for doing that was that they just weren't getting a lot of students that were kind of sticking with sticking with the program, with their programs. And so in the end, it's ultimately a widespread problem that isn't just related to health workers and global health and that sort of thing. And there are probably, it's almost certainly a multifactorial issue, but I think from the standpoint of a program like a degreed program or an online degreed program, there's a certain sort of person that tends to succeed in a program like that. It requires a lot of discipline. A lot of times the folks who are enrolled in programs like that are also working. So they have to find the time and things like that. So I think that there are some of these sort of self and interpersonal causes that can be in place and that can affect things. And I think also for people that are already in an organization, there are organizational barriers that can stand in the way as well. So one of the very common things that I hear on a regular basis and that we heard when we were creating the landscaping report was we heard a lot of people say, well, I don't have time for distance learning. I can't fit it into my work day. I just don't have time. Now, at the same time, those same people, if you would probe a little bit, you'd find that they don't have a problem going to a 2-day off-site or a 3-day off-site or something like that. But when you have distance learning that is supposed to be kind of fit into their workday, they have a hard time kind of getting it scheduled. So there can be a variety of reasons. There can be that they just are too busy, et cetera. But it can also be that their organization doesn't sort of carve out the space for them. It doesn't give them, they don't have a culture in place that will essentially encourage learning. So their supervisors they might look over their shoulder when they're online doing something that doesn't look like work and be discouraged from actually in getting involved in distance learning. So those are a number of the things that I think can stand in the way. And another thing that we found in the landscape report as well was that, especially in developing world countries, I would argue actually this worldwide, you'd find that there are a lot of biases related to distance learning as well. So there are a lot of people who simply think that you can't learn effectively with distance learning. And that certainly is true, but as an instructional designer, I shouldn't say that's true, that's not actually true. As an instructional designer, I think that there's effective classroom instruction and there's effective distance learning and there's ineffective versions of both. So if you have effective variants of distance learning, then in fact people can learn from it. And I think on that particular note, one of the things that distance learning as a field or as an industry has suffered from, and I think has served to kind of cultivate negative attitudes, is that there's been a lot of ineffective instruction that's been created and put out there, and that's served to kind of reinforce a lot of these biases. So in the end, just to kind of wrap it up or summarize, whenever I get into conversations about sort of barriers to distance learning in sort of resource-deprived settings, a lot of times the conversation does focus around technology. But in the end, I think that the technology problems are much easier to deal with than the cultural and the sort of human problems. Those are the ones that really present a bit more of a challenge to try to deal with. The fact is that if you have in a very resource-deprived area, there's always a distribution mechanism, and there's always a learning consumption mechanism that exists. Maybe it's a handset, and if those handsets don't exist, it could be even print-based. When people talk about networks for distribution, they think, well, internet doesn't exist, but roads and post offices do, and a lot of people that don't have continuous access to internet have periodic access to internet. So if you're involved in some sort of distance learning initiative, and you take the time to just sort of understand what the resource constraints are, you can typically find a technological solution that will help you get the training there. But the bigger problem is going to be, how do you kind of assess what the cultural barriers are going to be, and and organizational barriers, and then how do you address them?
Thank you, Nathan. Miriam?
Good morning, everyone. My name is Miriam Yanakis. I'm the Nutrition Policy and Partnerships Advisor for World Vision International. But in addition to my work in policy and partnerships, I also work with the Nutrition Center of Expertise. And one of the things that the Nutrition Center of Expertise within World Vision has been doing is trying to respond to some of the requests that have come from our field, particularly for e-learning. However, that's not the complete scope of the work that World Vision is doing within mHealth. mHealth programs within World Vision's scope are being implemented in about 18 countries in Asia, Africa, and Latin America, supporting community health workers through our behavior change modification approach, also through the community case management of acute illnesses, and using technology to be able to support community health workers to do their job better. And so, because of the topic of this panel being distance learning platforms, I am going to focus my discussion in sharing some of the experience we've had specifically with the nutrition modules. So the requests that we had from the field were particularly on areas where there was gaps, and so we've worked to try and address those, taking into consideration a lot of what Nathan was saying just now about some of the challenges. And leading back then to what's going on with the platform, some of the barriers and how do we optimize it. One of the barriers that we've seen from our experiences is just the complexity in the field of platforms and who is doing what and all of the different courses that are out there. And some are they're very closed, they're owned by their owners, and you have to pay to get into them. Some of them are free, and huge diversity in quality. And I think it's been one of the barriers. We've made a lot of progress to this point, but to get us to the next point, we need to sort out some of those issues. We need to answer those questions about how do we improve the metrics, how do we improve compatibility within the platforms, how do we get people to talk to each other, how do we get people to leave their egos at the door. We can say that. We all know that's incredibly difficult to do. Practically, how do we get that down? And I'm not here to say that we have the answers. I wish I had all the answers for you. I hope through our discussions here the next 2 days we'll be able to get to some of that. One of the things I do want to specifically talk about from our experience in nutrition is the need to be learner-focused. There's a lot of learning opportunities out there that is very linear. You take in your intake at the beginning, you put them through the hoops, and at the end they finish with their certificate. We have no idea whether any learning has taken place whatsoever, let alone any learning transfer going on into improving job performance. So within World Vision, we really tried to look at that and try and practice what we preach and try and put some of these things down to learn from it. One of the things that we started to do was an e-learning passport. And so all of our learners go through an assessment, which is not just web connectivity, but it's also social readiness. Your manager has to sign on to it. It's also your computer skills, and it gives you a green, red, and yellow rating. If you get a yellow in an area, there'll be some recommendations on how you could possibly decrease some of the barriers. If it's red across the ground, we're probably going to recommend that this e-learning platform, this opportunity is probably not what you need to be investing your time in, because there's so many people that get excited about e-learning. They sign up, they do the first couple courses, and then you don't hear from them ever again. The e-learning passport, we've not been able to do a specific evaluation on it, but we do know that our course completion rate is up to 90%. So 90% of the people that start our courses finish them. We think it's highly likely that that's due to that e-learning passport and providing that coaching up front. In addition is looking at how people learn differently. People don't learn differently. People in certain societies and cultures and learning environments learn very differently. So one of the barriers I think that we've had is that we assume that people learn academically, and in fact many people don't, right? So providing those opportunities where people have the chance to get out there, practice what they're learning, come back, build on what assignments they've done earlier, continuously improve and reflect. In our course on childhood anemia, we don't teach a list of iron-rich food sources. How can we do that for so many different countries? We teach skills on how to identify them in the local market. In the Democratic Republic of Congo, it might be caterpillars in one area. It might be mice in another area. It might be an indigenous vegetable in another area. We don't teach a list to memorize. We teach skills for them to identify themselves. And they go out and try it. They come back, share with the group, go out and try it again. In one of the courses that we had last year, we had a relief worker based in Syria and a relief worker based in South Sudan. Now, we don't get a lot of relief workers on our courses, but in this instance, we had two of them. And the two of them together there, through the various opportunities to interact, were able to provide support to each other. So I think these are some of the ways that we need to try and optimize. We've gone so far, we need to take it to the next step. Looking at the learners, I think, is a very key lens that we need to be using, and seeing how does it look from that learner's perspective, and how can we address it and make it interesting and appropriate and applicable for what they're doing on their job at this point in time.
Thank you. Sabina?
Yeah, thank you, Jane. It's a pleasure to be here. So my name is Sabina Beatrice. I'm a project manager at the Novartis Foundation for Sustainable Development. We're basically the non-profit arm of the pharmaceutical company Novartis. And instead of talking very generally about challenges with regards to the uptake of distance learning tools, I would like to share a specific experience that we had at the Novartis Foundation. And it's a specific tool platform called ICAT. I don't know if you've heard of it. It's basically an e-learning tool that we developed together with the World Health Organization and the Swiss Tropical and Public Health Institute for training in IMCI. So IMCI is the integrated management of childhood illness, so really the strategy of WHO to scale up and training in childhood illness and ultimately reduce child mortality. And the issues that WHO was facing with this IMCI training, which was supposed to be scaled up globally basically, was on the one hand the adaptation at country level. So basically WHO provides the generic guidelines to the countries, and then they need to adapt it to the local circumstances. And then of course, and that's why we're all here, how do you then go about training thousands of health workers in this new approach? And that is why WHO has then contacted the Novartis Foundation, and we developed this tool called ICAT. So ICAT is not just e-learning, but it's actually a software that enables countries through an open interface to adapt the content of IMCI to the local circumstances, and then helps countries create e-learning modules that can then be used to train hopefully more people. And so today we are at a stage where about 25 countries are using ICAT in one way or another, but we know that within these countries actually the scaling up is very limited. And some of the challenges are linked to the fact that IMCI is still quite a comprehensive training course. So even if it's taught through e-learning, you do need to include clinical sessions, so really face-to-face sessions. You also have a mandatory follow-up visit 1 month after the training that needs to be included, so that cannot be solved through distance learning. And then also, of course, I mean, the same things over and over again, lack of resources and infrastructure, etc., but then also often lack of a national strategy to go about scaling up this training nationwide. And then the last point that we found also, it's actually also there's really a lack of evidence of the effectiveness when it comes to e-learning compared to traditional learning. So many people, and I think it goes back to what Nathan said also, maybe don't trust e-learning or distance learning as much as face-to-face learning. And so to address this last point, we launched a study in West Africa in 3 countries, Cameroon, Burkina Faso, and Mali, to really compare ICAT, so distance-based ICAT courses with traditional IMCI classroom-based courses. And we started a study in Cameroon, and the findings were actually, on the one hand, positive, because we could show that costs could really be reduced by about half. So that's, of course, really a point where countries may then want to invest in. But then on the other hand, the learning outcomes of the students, and we measured not only the theoretical knowledge, but also the application, and also the application and the learning effect 6 months after the training. And there we saw that we could not reach the same learning effect with the distance-based learning tool as with the classroom-based tool. And then based on these results, we introduced some additional tools to help facilitate basically the interaction between the students and the facilitators. So for example, online questionnaires to monitor the progress of the students, etc. And so in the second phase of the study in Burkina Faso, we implemented these kind of additional tools, and this then already showed substantial improvement also for the ICAT group, and actually we reached basically the same level of learning outcome for the two. So we're now about to launch in Mali, and we hope to get similar results there. But basically, our to sum up, our learning is really that it's possible, but it's very difficult to do, especially for such a comprehensive course where you have mandatory clinical practice and follow-up visits, to do that via distance-based platforms. And what we really saw is that this interaction, tutor and student, is really the key. So for example, to have a meeting before the course launches, that the students get to know the facilitators, and then have maybe also some midterm meeting and again at the end, but then I have also this ongoing interaction, facilitate these things. That was really the key for us.
Mark?
Good morning, everybody. I'm Mark Mitchell. I'm president and founder of D3 International and lecturer at Harvard School of Public Health. And one of the great things about being the last person in a row on a panel like this is that the question's really pretty much been answered. And most of you have probably even forgotten what the question was. So I get to say basically anything I want. And that's what I'm going to do.
I'll keep you in check.
I've been working in global health pretty much forever. In fact, way before it was called global health. I've worked all over the world. And I've been working in M-health before there were M's, before there were cell phones. And in fact, my work really started because there was a shortage of health workers. And I recognized that, with task shifting, how do we get people to do jobs that normally would be done by more experienced, better trained people with very, very short training? And to do it in a way that was at an adequate level of quality. And it seemed to me the only way to really do that was by using standards. And IMCI is a great example of that, and that really evolved over a period of time as a set of individual standards and then integrated standards in order to try to get health workers at various levels, most recently community health workers, to know how to, in that case, diagnose and correctly treat kids. And there are other standards that are done for maternal health, for deliveries, for all kinds of things. And so my work really has been on figuring out how do you develop those standards in a way that people follow them and that we know whether they follow them. And that's really my particular niche in M-health. I do want to come back to the question, actually, of why people haven't embraced distance learning. And I think there are a few very simple reasons. One is that bureaucracies don't like change. People have been doing training for a long, long time. It's face-to-face, whether that is training nurses to be nurses or doctors to be doctors or anybody else. And when someone comes in and says, actually, we don't need this building and we don't need you either, people tend not to like that. And so they find different reasons that that's not as good. We can't track what's being done. There's lots of reasons. And, they don't like change. I mean, I teach at a university that has vehemently resisted distance learning for a long time. They're changing that now and introducing a distance learning whole program. And in fact, it's not really public, but you will eventually be able to get a Harvard degree using distance learning, or maybe not a degree, but a certificate. But for a long time, they've tried to prevent that because it wasn't consistent with their view of what's a university and how does it all work. So that's one problem. A second problem is money. So money drives a lot of things, and there's a lot of money to be made in training. In fact, trainers, the experts, right? We're all experts. We get paid for training. And if you come along and say, hey, I don't need you anymore, I have a video that does it even better, I may not like that. And so trainers have been resistant. Often trainers in many of the countries that I work are the senior ministry people, senior specialists, yada, yada, and they don't necessarily want to be replaced. Trainees don't like it either because they also get paid for attending a training. We're working in Malawi, and the donors in Malawi said, we're tired of paying huge amounts for per diems and so forth every time someone has a training, and so we're not going to let that happen anymore. You have to, we'll pay for the meals, you got to eat the meals. People stopped coming to trainings. They refused. They went on strike and said, we're not going to come to trainings anymore unless you give us the per diems that are why we came here, really. So you can't do that with distance learning. So that's another problem. And the third is organizations. So many of us work for organizations who have very profitable programs to develop and do training. I remember that when I worked for a consulting firm, a global health consulting firm, developing and doing training was the one way I got paid without traveling. You know, we did trainings, I had a month of preparation, then people came from all over to my training, so it was the month I could actually be home. So there's all kinds of financial incentives to do face-to-face training. It's not surprising that people resist it. And then the third reason I believe that there's been reluctance is actually building on something that Sabina said in terms of the IMCI training. I think much of the training that's being done is done in a very naive way. Oh, we don't need face-to-face, we're just going to do distance learning. Or we're just going to do, you know, these people aren't showing up for work and what they really need is training. I don't think so. And I think that for training to be effective, we need to be much more thoughtful about how do you mix face-to-face training if you're teaching skills with distance learning if you're reinforcing things. I know that Japigo talks about low dose high intensity or low dose high frequency training. And I think that's probably a better way to learn things so that you learn something, you practice it, you realize you didn't actually know it, you get refresher training until you really know it. And so I think that one of the things that's needed is a much more nuanced approach to training that combines face-to-face, distance learning, thinks about the skills, thinks about how do we get it to people in a way that they can use it when they need it, just-in-time training that we're working on, so that when you need a skill, you can learn how to do it and then apply it. So I think that all of those things are really preventing the uptake. Thanks.
Yeah, thank you very much. Some great comments. I'd like to open it to the audience at this point to please, you've heard what the panelists had to say. I'm seeing hands go up, great. So let's go start with you there and then move over here.
Hi, my name is Hilde Euglink. I work for ISD, Dutch NGO specialized in the use of ICTs. We have a quite successful program now in Malawi for whereby nurses and midwives use e-learning to renew their license. It seems to pick up quite well. I was wondering, hearing about all the obstacles and challenges, has there been done any kind of research into the complexity, the level of complexity of content that needs to be, that can be, that can be offered via means of e-learning? Is that a kind of, because I'm just wondering why the work that we do, it seems, like I said, it seems to pick up really well. Maybe there is a kind of, because it's enforced by law to renew the license. And nurses and midwives in Malawi need to pay for their own travel cost. You need to take time off work to attend the course. So there is a clear benefit for nurses and midwives to use e-learning. But I was also wondering, I do not know exactly I haven't seen all the course material, but it might also be maybe it's also kind of relationship with the type of content that needs to be learned, whether that is a kind of like factor that really prevents the further uptake of e-learning. Like I said, I think it seems to work in the setting that we work, but maybe I wonder maybe that's just because the courseware or the content is not that complicated for the kind of skills that they need to be trained in.
Thank you for your comment. It's interesting that two of the reasons you mentioned for success of your program were two of the barriers that were mentioned from this end, in terms of, in your case, that the participants actually had to pay their own way in terms of going to the training, whereas a lot of the obstacles, they were actually getting paid. And also that they were mandated, that they were required to do this particular training, and that's not often the case. So I'd like to open, would someone like to respond? Go ahead, Miriam.
Thanks for your question. Perhaps I'll leave the research question to the academics on the panel, but one of the things that I think strikes me about what you're saying is resonance. And one of the things that we're trying to do with our learners is to find that point where we meet the learners. This way. I have a 7-year-old daughter, and she loves to swing, right? She loves me pushing her really high on the swing. Now, if I'm standing behind her pushing her, I have to push her at the right time with the right intensity, otherwise we're both going to be in the mud, right? I have to wait until she comes back and starts going again, and then I push her. And that's the visual that I have in my mind when we talk about learning. It's providing the learning when it's needed, at the intensity that it's needed, when it's in sync, not with the developer, not with the facilitator, but with the learner themselves. And I think what strikes me about your experience with the midwives in Malawi is that you are getting that resonance, that you are getting something that is needed at the right time, at the right intensity, and that's making it flow perhaps easier than other people's examples.
Anyone else?
Yeah, I'll add something. So when I was in my PhD program, I was in an instructional technology, instructional design program, and from the day that you got there, everyone that's in the faculty and on your committee, they say, when the time comes for you to propose a research project to us, we're really hoping, in fact, they're saying, don't come to us with an idea that compares the effectiveness of different media or different channels. Don't talk to us, because they're not comparable. And the story that they tell is this. So if you were to say that you took a lecture on a particular topic and you presented that live in a classroom, and then you had a videotape of that same person giving that lecture, but you showed it on videotape, if you found any differences at all in the live, so let's say though that in the live session, so the people were able to ask questions, but in the video session, you're not able to ask questions. Well, if you found any differences in outcomes, it would be hard to say that it was the video per se. It was the fact that you could ask questions. And so if you'd shown the video and then had someone come in and answer questions, so the point is that in order to strip away all the variables required to make them comparable, they become incomparable. A video, if you basically have a classroom where someone lectures and you're not allowed to ask questions, and you videotape that lecture and show it to someone, any differences that you see in outcomes are going to be there purely a matter of chance. So in the end, what's pounded into our heads is it's not the media per se. Certain media allow you to do certain things, and those can make a qualitative difference in your outcomes, but it's not the media per se. It's what you're doing in that particular venue. So there are a lot of things that your question brings up the whole plethora of, so why did it work? There could be a whole plethora of things that we've just talked about. So it could be the instructional approach. So there could be instructional approaches that are more effective. If the question is, why did more people choose to attend it? That's a different question than why was it effective? And there can be a lot of different reasons. So it's just like you're saying. So if I know this is a strange analogy, but it's sort of like I use this a lot. So if it's a Sunday afternoon, I'm trying to relax and watch a football game, and my wife comes in and says, I'd like you to mow the lawn, and then 2 minutes later, I get a phone call and someone says, hey, I offer lawn mowing services for $25. I'll come and mow your lawn. Well, guess what? I'm going to hire them, and I'm going to say, go mow the lawn because I want to keep watching my football game. And I think when it comes to the choice of topics that you use, if you're using topics that meet a need that are associated with people's professional challenges, their personal goals, and things like that, and you take the time not just to figure out what those are, but to frame your content according to those things, then you're going to have a much better chance of uptake. But then the fact of the matter is that in addition, for any organization, whether you're talking about a health ministry or a corporation or whatever, there are always going to be topics that get pushed down. It's just the way that it is. In order to operate as a unified, coherent whole, there are going to be strategies that are developed, and they're going to have to be pushed down. So in the end, when that happens, you're going to end up with content that may not be as motivating to particular individuals. And so at that point, you need to think about organizational levers that you can pull that can provide them with a external source of motivation for actually attending the training. So those can be standard things like associating them with some sort of a performance review or mandating it in some way. But you can also create sort of internal credit systems and badging systems and things like that that can kind of help to motivate people.
Thank you, Nathan. Honey?
So I'd like to joke, what's the difference between a training and a class? The difference is in a training, the participants grade the speaker. In a class, the teacher grades the students. It matters because when you grade people, you can ensure they do the work. So I teach graduate students, and even though they're really busy, they all do their homework. They all do the reading. They all participate in class, because that's the expectation, and there's a consequence if they don't do that. I think that we are a bit naive when we do trainings, and people go for a variety of reasons, often for the per diem or the trip to wherever it is. They may or may not be interested in what we're training, and they don't learn that much. And I think we need to not just think about how to use distance learning, but think about how to really get incentives so that people want to be there and learn. I like your model that people pay. Not because it matters that you pay, but if you do pay, it means that you were willing to be there and wanted to be there, and therefore are going to demand that you get something out of it. So I think it's really a rethinking of how do we get people to actively engage in learning rather than what's the medium for training.
Agreed.
Maybe just to
Oh,
add
sure.
one point, sorry, to what you said. I completely agree with the flexibility. I think that's very important that these platforms allow for the flexibility so that you can really meet the needs of the learner, basically, and individualize, for example, the modules. But then on the other hand, I think we have to even go beyond, as I said before, the distance learning and just, know that some topics can maybe not be necessarily be taught via distance learning. So especially in medical topics, I mean, there are some things that you simply do need to attend clinical sessions, but then also, for example, now we're working on modules on antenatal care, and there's you do need to have some role plays and some actual social interaction to really get the content to the students. So I think that's also the limitation then of the distance learning as such.
Yeah, and I think that reinforces Mark's comment about the thoughtfulness towards when blended learning is needed. You had your hand raised over there. Please.
Good morning. My name is Firdaus Karas. I'm with Chocolate Mousse Media, and I'll be talking tomorrow. But I want to just build on Mark's excellent list and pick up on what Nathan had just said. I do admit that I'm a distant learning dropout. And the reason I'm a distant learning dropout is that I did sign up for a course on international health, global health, from a very prestigious American university. It wasn't Mark's, but it was a peer of Mark's. And I dropped out because, frankly, it was just simply boring. It was boring. Until you get compelling content, until we change the way that we actually try and get people engaged, you're not going to be able to succeed in it. And when I was listening to this lecturer who was lecturing to me in Europe from his base in the US. The only difference I could think of to my experiences when I went to university in the 1970s in the US was simply that I was watching it on my computer instead of being in the classroom. Other than that, there wasn't any difference. Nothing has evolved since the 1970s in how we deliver the content, how we engage the student, how we bring the student into the classroom, even if he's not or she is not physically there, how we make sure that the student remains engaged. So I was highly motivated. I believe in long-term education. I have 7 degrees and certificates. It was on a topic I wanted to learn more about, and yet I did drop out. So I think that the content side, we can talk about the technology all we want, but until we have compelling content and different instructional ways to deal with it, we will not get the students of the world engaged. In today's world on the internet, where all young people especially are watching compelling content on the internet.
Thank you for your comment.
I think one of the problems as well is we don't always learn from other more successful e-learning or e-type environments. If you look at someone like Sugata Mutri, who does the School in the Sky, and where he's encouraged these kids in very rural areas to learn by themselves on computers that are just attached, and they've learned how to program, even though they're not English speakers themselves, they've learned how to program in English. And one of the studies he did was comparing the learning environment of those kids to another school in a more sort of urban environment. And he discovered that the testing results were not the same. So what he then did is he encouraged one of the local bookkeepers in the small village to just encourage the kids. And she said, I know nothing about science and technology, I'm just a bookkeeper. And he said, no, all you need to do is just pat them on the back and say, well done, you're doing a great job. And then their scores ended up equaling those of the urban kids who went to the private science and math schools. So I think trying to learn, so it's not just about how you teach, but it's creating the environment in which e-learners learn. So how can you find pockets of people who learn from each other, and whether it's directly from each other in that same environment, or in that they can interact with each other, because I think learning from other members of your classroom is a much more exciting way to learn than just from the person who's teaching you.
Mm-hmm. The idea of creating a learning community. I think there was one other, yes, in the back.
Dickie Settle from IntraHealth International. I've heard a lot of good reasons today why distance learning really doesn't work really well, and why blended learning is a little better. And so thinking about in-classroom learning in some of the global health contexts, one of the biggest challenges that we see with achieving the goal, which is delivering knowledge in a way that it will be practiced, right? So in achieving that result, as we see, and Mark already touched on this, people in power are getting selected and routinely getting to go to the trainings to collect the per diem, which in turn, of course, pulls them out of the practice locations. And so there's several issues with this with the in-person training model. Do our experts on the panel have a sense of evidence that distance learning approaches are improving the reach of this learning to reach more people than in-person training does because of the political realities in these countries, and also helping to support those students to stay in practice and not be pulled from practice?
Thank you. Who'd like to comment on that? Go ahead, Mary.
I think there's some really, there's a lot of great expertise in the audience, and I think we could talk about this for a long time. I think the idea of how do we make blended learning work is, it's another question that is really interesting. When I look at what we've done, just with our very small example with the nutrition, in that training process, we hold it with a very open hand. It's not something that is very closed for World Vision. Within the past year, we've had 23 different organizations based in 37 different countries that have been able to go through the trainings on the job, nobody coming in away from their job. In any of our face-to-face trainings, and tell me, World Vision has done a load of face-to-face trainings, we haven't been able to do something like that. So I haven't done the research on it. We haven't looked at it from that perspective, but I just know from our own experience that this The way that it's done, that it's open, the way that it's a specific module, that it's not expected to be a complete training in a certain approach. It fits with many different models and many different approaches. People are taking it because they want to build their technical expertise and their competence in a specific area. That's enabling the learning to get out to areas which it hadn't been able to get to before. And when we get the feedback from our learners, so many times it's, you know, I never get to go to the trainings. I'm never the one selected, but I've been able to learn about anemia through this modality. And so we've been very encouraged by how we see this getting out. Of course, we do have to remember that as we move towards technology for training, there's always people that will be left out. This doesn't reach everyone that we need it to reach. So although I think we've made some good progress, it's not the be-all and end-all of training, and I think blended learning and figuring out how to make that work better is a serious discussion that we need to have.
Dr. Bollinger.
Thank you. This is a great discussion. I have two quick questions for the panel. One of them is about measurement of success. In the context that we're here this week, we're focused on training healthcare workers, and this has been alluded to, I think, by Nathan and others, that we're measuring skills, not just knowledge base in clinical medicine. And one of the challenges that we always face when we develop training programs, whether it's online learning or whether it's face-to-face, is to begin by defining what problem we're trying to fix. What are the competencies, what are the knowledge and skills that are necessary for the learner to fix that problem, whether it be taking care of a newborn or whether it be, you know, screening for HIV and counseling. And a lot of what we're trying to get people to learn are skill-based. And the challenge is always, for us at least, is how to measure that with limited resources. And there was some talk about, I think somebody mentioned how they're measuring skills as an outcome. So I'd like to kind of ask a little bit about that and how you measure skills in the clinical setting. We use a lot of distance learning, but I think it's a tool. It's a tool of many tools in the toolbox, whether it be online learning or mobile health or face-to-face. And the second point is around something Nathan said about the value of instructional designers. I think if we have a well-designed program for training health workers that's focused on the skill that we want to teach, and we use multiple ways to deliver that training, we can accommodate a wide range of learners if we're smart about it, but we always have to focus on that skill that we're trying to teach, or that competency. So the second question is really back to the incentives for learning. I mean, why do people want to learn? Why do they need to learn these competencies or these skills? Well, sometimes because they're required to. I mean, the continuing education, multi-billion-dollar industry in the United States is a great indication, a great example of that. People pay for education because they have to, because if they don't keep their certification. The other is to give people other kinds of incentives, such as measuring the right outcomes and the skills. So if people are practicing what they learn, and you find a way to incentivize them, either pay them better, congratulate them, give them minutes on their phone, whatever is necessary in addition, or professionalize them because of what they're actually that knowledge being applied. Perhaps it's another way to incentivize. I'd just be interested in other types of incentives that people have found successful other than just monetary. The other final thing is just an anecdote. Having taught medical students at Hopkins for 25 years, one of my favorite comments recently from the new learners about a course that I taught, which was a traditional course, and was, Dr. Bollinger, this was a great course. It'd be a whole lot better if you would provide us wiki-like summaries of what we needed to know ahead of time. And so I think it's back to defining the competencies and the skills that are necessary. And sometimes our learners don't always know what those are. But be interested in what others think.
Let me see, Mark starting. Go
Let me
ahead,
see
Mark.
if I can field some of that.
And one moment. I just want to make everyone aware of time. Keep your comments brief. I want to just be able to ensure we have allowed enough time for audience. Go ahead,
Okay.
Mark, please.
I actually don't think measuring skill competencies is the end of the line. I'm interested in whether they use the skills, whether they use them correctly, and ultimately health outcomes. What that says to me is that we can't just evaluate the training. We need to evaluate the care. And we need to think about ways to do that. I mean, we have an advantage because the health workers that we train go home with a phone. And that phone has very specific things that they are meant to be doing, and we track those as they're doing them. We also have a very particular kind of distance learning, which is if they're having a problem with something, they have a phone. They can call somebody and we give them a number, and they use that a lot. So I think that it's a mistake to actually just evaluate the training without thinking about the broader context of what it is they're trying to do. Were they even the right skills that they needed? And I think that's the challenge. I think there are ways to do it, but it's not easy.
Thank you, Mark. Nathan, did you have a comment?
I do. So when you were asking your question, one of the things I thought about was a case that we profiled in the landscape report of an organization called Digital Green, which actually started in the ag space. I'm not sure, maybe some of you are familiar with Digital Green, but one of the things that Digital Green is doing, so Digital Green has this program that actually, I think, if I look through and I say, well, what are kind of the challenges that you often find in delivering and measuring, there's a measurement component into it, but in delivering distance learning to a resource-constrained audience, they kind of hit a lot of them. And so what they did was, Digital Green was focused on ag at first, now they're moving into healthcare, but what they do is they have a solution set for teaching ag and they started in India, to very rural farmers. And the solution set essentially has three basic components. One is a really low cost, off-the-shelf technology suite that allows you to create videos and then take them out to the rural settings. The other is a simplified training system that can train extension workers how to create a video of sufficient quality to teach someone a particular agricultural technique. And then the third leg of their solution is a portal that brings it all together, and so whenever the extension workers create videos, they can upload them. And so the idea is, once an extension worker has been oriented to the Digital Green solution, they can either create a video of their own, or they can go to the portal and download some videos. Then they take it and go out into some community, and they, with a small projector, and they project it up onto the side of a house or on a sheet, or whatever it is. They get the farmers around, they project it, then they carry on facilitate a conversation about it. And then they have the ability to enter in, okay, how many people showed up, what did I teach, et cetera. And then the system allows, the extension worker goes back, and that at any point in the future, the extension worker then can go back out into the field and determine and look and see, okay, well, did people actually use this potato staking technique that we taught them or not? And then they enter that back into the system. And then what happens is, for each of the communities, they cover all these metrics about who's using it, how effective it is, and those are broadcast to everyone. So all of the communities can kind of see themselves. So it has a little bit of an element of, there's an element of measurement, there's an element of competition, and there's so many features of that solution that I think are worth noting when it comes to the general topic that we're discussing.
Thank you. We have just another minute or two. Is there any final comments from the audience? Okay, and it can only take one. You. Yes, you. Oh. And then I'll ask the panelists for any closing comments.
Thanks. My name's Jeff Dresner. I'm with Clinical Care Options, and it is a pleasure and a delight to be here. I wish we could bottle mark for all of us who really try to engage in any level of innovation, because I think you really did answer one of the questions that came up in the previous panel, which is the whole notion of pilotitis and why so many pilots don't go anywhere. And it's because they are innovative, but people don't look at them seriously enough because they would rock the boat and they would ask them to change how they think about education. The other points I wanted to make is I think people do embrace medical education on a distance learning basis all the time. And I want to make that point because we create programs for the West in HIV, and we have 20,000 doctors and nurses in Africa who read those programs all the time. And when we go into the country and we talk to people about what we're also now doing for Africa, they all say thank you. And we use the programs, and we use it for teaching, we use it for mentoring, and it has really been an effective tool. But the other point I wanted to make is that there's another lesson to be learned by how physicians, and even more so the younger physicians in America, are now employing the use of the internet, which is that what we find is that the younger physicians, when they finish training for in-service training, don't take the traditional CME courses the way they used to. They use the internet the way everyone uses the internet. You search for a bit of data. You search for an answer. And I think we're going to see that globally as well. And we need to be able to change our models and change our approach to medical education that works to reflect that, very much the way Bob was talking about his students saying, I want a flipped classroom, and we're going to see more and more of that, and that also helps to integrate online and live thinking and models. One of the things that we did to try to respond to the notion of what's the incentive to use a particular program is to make it simple, to make it a deep and rich curriculum that's authored by African experts, not Western experts, but also to flip the model in a way that allows people to search using new technologies offline as well as online to search the content to get answers at the point of care. And I think if we can really, all of us, think about building those kinds of models, we will serve, the needs of Africa in a new and innovative way.
Thank you. I'd like to ask each panelist to just take about 30 seconds or so to make any closing comments. Nathan, we'll start with you and go down.
Okay, so my closing comment, I'll try to keep it to 30 seconds, is
timing you.
I've heard the sentiment expressed that, okay, well, maybe distance learning isn't really good effective way of doing this. And I guess I want to counter that by saying, I hope that's not the message. What I think the message may be is that getting it right is a little bit more difficult than it seems. And in fact, perhaps the reason why we've seen plenty of successes, but the reason why we sometimes see failures is because just enough care hasn't been taken to create really effective distance learning. So in the end, the models for doing it well are out there, and they've existed honestly for decades. There's nothing like when a lot of times when the innovative models are pointed at, like Khan Academy. Well, look at what Khan Academy's doing. They get spaced instruction. It's mastery based. The thing that's new about Khan Academy isn't any of those things. It's that it's free. That model of instruction has been around for a really long time. The problem is or I think the question that we should be asking ourselves is, if we have successful models, and we do, and they exist and they're plentiful, why aren't they in more widespread use? And I would argue again that we're talking about cultural issues and organizational issues and things like that. So if we're really going to get there, I think those are the main issues that we've got to solve.
Thank you, Nathan. Miriam?
Thanks for the opportunity. I think we've heard a lot this morning so far on innovation, and it's really encouraging and great to hear. I guess one of the pleas that I would have for the innovation is to focus the innovation more on the how. How do we take it to scale? So much of the what we know, but how do we really get it to scale to improve the quality of service that's being delivered in the most rural communities in developing countries around the world?
Maybe just to add one aspect that has been neglected a little bit, which is pre-service training. I think we often focus too much on the in-service training, and we've seen this also with IMCI, which is mostly taught in-service training, and you then have often the health workers who come back from this training, but he may be the only one in a health facility actually trained in this, and so maybe he's not really going to apply the new skills. So actually shifting from focusing very much on this in-service training to the pre-service training would help to really build the skills at an early stage, and then you could much more easily build up on this later on. So the issues we talked about, like incentives, you wouldn't have to deal with as much because the students would be incentivized already because they have to do the training, and also infrastructure wouldn't be as much of an obstacle. So that is something to think about as well.
Engaging content. It's not so simple to go just from the classroom to a video. And also, finally, meaningful incentives. We have to be sure that meaningful incentives are in place if we're really going to see an uptake in distance learning. So on behalf of the panelists, I'd like to thank all of you for participating and thank the panelists for joining me here today.